So I am going to introduce our next speaker, Dr. Mike Green, who is an esteemed colleague from the Radiation Oncology group, and he's going to be talking about the role for radiation oncology in melanoma.
Hi, everyone. Thank you so much for the invitation to speak, Dr. Lau, Dr. Fetcher, and all of the AIM group here. I'm following some fantastic speakers, so I hope to just highlight and coalesce everything that we've learned today. As they mentioned, my name is Michael Green. I'm a radiation oncologist. I have the privilege of practicing here with Drs. Lau, Fetcher, and everyone else, and Angela's here at the University of Michigan, as well as across the street at the Ann Arbor VA. And I'm a radiation oncologist. There we go. I have no disclosures. And so I think we've heard today from a number of exquisite speakers on how we can use surgery, systemic therapy, and now radiation, which is a non-invasive form of treatment that focuses on damaging the DNA where it stands to treat melanoma. And as I'm trying to indicate here, we use these complementary modes of treatment in different settings and in different ways. And so for patients, as shown here on the left, who have very early stage or localized disease, we really rely, as Dr. Angelis mentioned, on surgical excision for the adequate management, wherein patients with slightly more locally advanced disease, we use a combination of treatments. As Dr. Lau mentioned, sometimes neoadjuvant immunotherapy, sometimes adjuvant, sometimes we use radiation, and again, all resolving around the use of surgery as well. And then as the disease, unfortunately, in some patients becomes more widespread, we often rely a little bit more on systemic therapy treatment options, including the targeted therapy and immunotherapy that Dr. Fetcher just mentioned. And some, in select patients, we can also use radiation either for the assistance of the curative intent or palliation of symptoms. And so that's what I'm focusing on here today. And so, just very briefly, we typically, as I mentioned, rely on the surgical excision of localized melanoma. However, we sometimes use radiation in very select patient populations. Some rare cancer subtypes, such as desmoplastic, sometimes recur more frequently locally, or in patients who can't undergo a surgical resection or whose cancers cannot be removed. We can sometimes use radiation in these patients, and that's really all I'll say about that. When the cancer is spread a little bit further, there's sort of a variety of paths, and each patient sort of needs to discuss with their multidisciplinary team how best to manage this situation. I'm just going to call out one specific example of how we use radiation in select patients. And so we've seen in years ago that we took a variety of patients with high-risk features where we were concerned that their cancer would come back in the lymph nodes adjacent to where their tumor arose from. And then we conducted with Dr. Angelis and many of our colleagues complete removal of both the primary tumor as well as the draining lymph nodes. And then we randomized patients to observation on radiotherapy. And we saw in the patients after many years that the use of radiation in these patients actually diminished the recurrence of the cancer within the draining lymph nodes slightly, but this trial was run a long time ago, and there's been so many updates to the management of these locally advanced care patients that we really don't know the best path. And so this is just one option among many others for the management of this type of cancer. And so another thing that frequently arises is how we can help patients either achieve cure or minimal symptoms in the unfortunate circumstance where cancer is spread more widely throughout the body in stage 4 disease. And so there's many types and flavors of metastatic melanoma. And one common occurrence, especially for this subtype, is where the cancer spreads to the brain. And obviously swelling of the brain can cause a lot of symptoms and difficulty thinking. On the right here is 2 axial slices from a T1 post or post-contrast MRI. You can see there's enhancing lesions at different locations in the brain. And we have many excellent ways of dealing with this problem. And so options, even when cancer is spread, remain fantastic. And some of the ways we deal with this are immunotherapy alone, especially for small or asymptomatic brain metastases. Thankfully, a lot of the therapies that Dr. Lau and Dr. Fetcher can provide are able to pass into the brain and are active here. And so we don't even need to do anything else except wait and watch carefully. But sometimes if there's more tumors or the tumors are causing more symptoms for you or your loved ones, we can rely on removing them surgically or treating them where they stand with radiation. And so what this looks like in particular in patients with fit performance status who have a lot of treatment options remaining is a form of radiation called stereotactic radiosurgery. This is, again, a series of MRI scans of a patient who had approximately 4 brain metastases. And overlaid on top of that MRI is just a radiation plan shown here in a heat map form, where the blue is very, very low doses of radiation and the red is very, very high or ablative doses of radiation. And so what I'm simply trying to show here is that we can target very small foci of cancer without going into the brain with radiation and sort of ablate it where it is. And so this is very useful, again, in patients with limited amounts of disease. And we also know that obviously surgical excision of cancer that is spread to the brain can be very helpful. And we weren't really sure for a long time whether or not we needed to do additional treatment after surgery or if removal of all of the tumors in the brain was enough. And so I'm just highlighting another clinical trial in approximately 100 patients with brain metastases. About 1 of every 5 of the patients on this trial had metastatic melanoma. And they underwent complete surgical removal of those brain tumors, and then they were randomized to 2 arms. Some patients were just watched very carefully with MRIs, and other patients received adjuvant radiotherapy, either that radiosurgery I showed or other forms of focal radiation. And we found, interestingly enough, that that surgery alone, in particular in the brain, isn't really sufficient. So unlike what Dr. Angeles can achieve, it's very hard to excise even 1 more millimeter of extra tissue in the brain. And so we found that the inclusion of adjuvant radiation in these types of patients can really help us achieve excellent long-term outcomes and prevent the cancer from occurring. Unfortunately, some patients have too many brain metastases to receive focal therapy, but I do just want to highlight, even in this subset of patients, that there are advances in technology that help us minimize the impact of therapy and still help these patients. And so this is a different type of non-focal radiation or whole brain radiation. We've less and less enjoyed doing this or providing this to our patients because we know that whole brain radiation can impact the ability to think clearly, in particular influences short-term memory. But we also have known for many decades that the most active part of our brains in terms of the cells that are still dividing and helping us form memory is the hippocampus. And we found more recently that if we can simply focus the radiation to avoid the hippocampus shown here, so the gray areas are receiving very, very low or no doses of radiation while the rest of the brain is sort of comprehensively treated with radiation, that this hippocampal sparing technique can actually help preserve short-term memory while still providing that comprehensive treatment that some patients need. And so there's many ways we can use very focal or careful or conformal radiation in the management of patients with brain metastases. Another scenario that we see not uncommonly is that melanoma or other cancers can spread to the bone. And this can cause a lot of symptoms or limit one's mobility, or even in some unfortunate cases, interfere with the nerves in the spinal cord and really disconnect our mind from our bodies. And in all of these cases, again, we have excellent treatment options in conjunction with all of the systemic therapy treatment options you've mentioned. And I just want to talk about what some of these look like. So that you know for you and your loved ones that there are options for dealing with this. Traditionally, and by that I mean over the last 30 years, we did something on the right called spine external beam radiation. And external beam radiation, again, this is a cross-sectional CT. There's a bone, there's a metastasis in this vertebral body here. External beam radiation typically used large fields of radiation. It usually required coming into the clinics every day for 2 to 3 weeks, and it covered a large area. And while this was effective at alleviating pain and providing local control, we were not always satisfied with this. And advances in technology in the last decade have really enabled us to provide more conformal treatments with higher doses that require less number of trips to the clinic. And the consequence of this, even in randomized clinical trials, is that it improves patients' pain. And so the majority of patients had a significant improvement in their pain when we provided more focused or stereotactic body radiotherapy approaches as compared to conventional approaches. And so this is another technique you can talk to your physicians about if needed, to a more modern approach to assist with bone metastasis. What this often looks like is that we can still cover large numbers of involved vertebral bodies or bones if needed. And through the use of very conformal beam arrangements, we can cool off the radiation plan or provide very, very low doses, for instance, to the spinal cord, which we obviously would like to treat minimally with radiation, and therefore help achieve local control, extend the benefit of the therapy many of you have seen or will continue to receive, and help our surgical and medical oncology colleagues. Sometimes the tumors in this area of the body, this is a vertebral body, the tumor here shown as red, can grow too close to the spinal cord or the nerves for us to be able to safely ablate the treatment. And so again, multidisciplinary care provides us a lot of ability to help these situations. And so we found in these situations that working with the neurosurgery colleagues, if we can even get 1 or 2 millimeters of separation between the tumor and the spinal cord, we can then apply very effective ablative doses of radiation. And so we work with our neurosurgical colleagues, and here's just 2 views of how that tumor is sort of pushing the spinal cord. And our very skilled neurosurgery colleagues can actually remove much of these tumors, if not all of it. And similar to the brain, we like to provide very focused radiation treatments, again, avoiding the spinal cord here shown in the middle of this sort of donut hole, while still comprehensively covering the areas of involvement, enabling us to minimize the potential impact of this situation on you. A final very common scenario that Dr. Fetcher just alluded to was that cancer sometimes, and melanoma and uveal melanoma in particular, can sometimes spread to the liver, shown here. And in addition to Dr. Angeles, I also have the privilege of running a preclinical laboratory here at the University of Michigan, and we study these patients very carefully. And so we know that macroscopic features, including the presence of liver metastasis, are really associated with limited benefit from immunotherapy. And work from our group and many others have shown that in mice, if we actually place a liver metastasis in a mouse, they actually cause the immunotherapy to fail. And so why is this? And to explain this, I just need to quickly talk about the cancer immunity cycle. This is one of our favorite metaphors for how the Pac-Man that Dr. Lau was alluding to can actually recover. And so this is a circle in which melanoma and many other cancer types undergo either spontaneous or therapy-induced cell death, and then the pieces of the melanoma travel or are carried by our antigen-presenting cells, our innate immune cells, to the lymph nodes, where they can wake up the Pac-Man, so to speak. And those Pac-Man have to travel all across the board, as Dr. Fetcher was alluding to. And so they have to go all the way through the blood vessel, and they have to go through, sort of go outside the blood vessels into the tissues, and then they have to go into the tumors, and they have to find the tumor cells again. And this whole cycle is very complex and is regulated at many levels. And unfortunately, we found that the Pac-Man, the T cells actually get a little bit lost in patients with liver metastases. And so we've seen both in patients and in our models that during the trafficking phase, where they're trying to find their way back to the tumor, that many T cells end up honing just to the liver. And within the liver, unfortunately, those T cells, those Pac-Man, die. And without those T cells, it's very hard for the immunotherapy to be effective. And so we've spent a lot of time trying to solve this problem. We continue to try to solve this problem. We can also apply very conformal high-dose ablative doses of radiation to tumors within the liver. We do this by using multiple arcs of a non-invasive beam, and then this, through focusing thousands of small beamlets just on one specific area, we can really potentially even ablate or control local tumors within the liver. And so we now are seeking in ongoing clinical trials here at the University of Michigan Dr. Lau and I are the co-PIs in a trial called Hammer, hepatic ablation of metastases to modulate and enhance immunotherapy response. We're really testing some of these preclinical models and associations we've seen in our patients, where in some patients, the T cells are going to the liver, and unfortunately, very few T cells are coming out. And now we're testing whether or not the addition of liver SBRT can actually restore the circulating number of T cells, overcoming that trafficking problem I mentioned, and seeing if we can enhance anti-tumoral immune efficacy in our patients with melanoma. And so I think we're running a number of fantastic clinical trials here throughout the whole team. And it's just a privilege to work with all these wonderful people. And so even when your cancer is progressing, the Immunotherapy mission is a fantastic place that can offer options, even potentially curative options for the last stage. I have to acknowledge everyone that works in my group. This is just some of my very young graduate students. I work with a very large team of residents, undergraduates, graduates, all these wonderful people that you've heard speak today. And of course, we're just so thankful to all of you. It's so motivating for us to hear you speak. We're so dependent on your support and your involvement, and thank you for fighting with us against this terrible disease. Thank you so much.